we had our physics PhD student who did a great meta-analysis on the dosimetry of lutetium PSMA-617, combining all the data that has been published out there in PubMed so far. So there is the two main PSMA-targeted lutetium-based therapy approach are lutetium PSMA-617 and lutetium PSMA-INT. And so he compiled all the data from these two compounds in terms of dosimetry. There was no major statistical difference. A lot of heterogeneity among all the reports that has been published since probably 2015. So a lot of heterogeneity. But at the end, it seems there was maybe a slight trend to say that the kidney dose might be slightly higher with PSMA-INT. We don't know how clinically significant that is, but just from the signal you receive from the images that you use to try to estimate the dose, it seems that it's a little bit higher. That the dose to the salivary gland and the lacrimal glands is a bit higher with 617, and the tumor dose may be a bit higher with 617. So the main limitation is that all that is based on images that you acquire in patients and from which you will try to derive using various dosimetry methods and estimations methods. You will try to derive a dose in gray. So there are many limitations to that process. There is a lot of heterogeneity into what was been reported. So it's unclear how these numbers suggesting these potentially slight differences in doses are actually clinically meaningful and would really change something in patients. We presented a poster of a trial in progress. So it was a study protocol that was presented at SNMMI. It was also presented at ASCO. This is a study that is about to open. We're like now mid-June. So we hope to open by the end of the month. It is an investigator-initiated trial supported by Novartis. It's a randomized phase 2 trial that will compare patients with second-line mCRPC, basically the one that would be eligible for receiving lutetium PSMA-617 therapy, Pluvicto, or the vision-like patient. They will be randomized into two groups. The first group is the control group. They receive lutetium PSMA-617 up to 6 doses. The time interval between each dose is 6 weeks, and that's a fixed set of 7.4 giga recurrent activity. And then the investigational arm, that's what we're going to try to explore and investigate, is an extended and flexible dosing schedule. So patients can receive up to 12 cycles, and they will be monitored with SPECT-CT imaging at each cycle. If they respond well, if they have a great response by both PSA and imaging, then they can go under treatment holidays. We pause the treatment. We don't see any disease anymore. We don't want to add any additional toxicity. We want to delay the administration of the next treatment to further, push the next progression date. We wait. We monitor the patient with PET-CT every 12 weeks. And if further disease is coming back, either by PSA and or imaging, then we retreat again up to 12 cycles. And so by doing this re-challenge, using a flexible design, we hope to be able that in some patients that really seem to benefit from the drug either super fast after 1 or 2 cycles, and we don't want to give the whole set of 6 cycles as a whole. We want to wait and push. Or the ones that have still some disease left after 6 cycles, you want to treat with additional cycles. So for these two groups, this trial will investigate how up to 12 cycles and using a treatment holidays flexible schedule can help them. And we will compare the overall survival at 2 years between the control group and the interventional group. So the oligometastatic directed radiation therapy is now a common practice think since even before PET, but now even more with PET imaging, even more with PSMA PET, but more importantly in the hormone-sensitive space. In that study that we presented with Dr. John Nikitas, this was done in patients with castration-resistant oligometastatic disease. So here, the addition of, focal radiation therapy to few sites of disease in a disease that is already castration-resistant is more unclear. There is some debates about that. And so we report here the outcomes of patients who are castration-resistant, who have only limited amount of disease, and who were treated with radiation therapy in addition to another systemic therapy agent, and report the outcomes. I think in some patients, it can be very beneficial. It can further delay and push the next systemic therapy change. So that can be of benefit in some patients.